Hello and welcome to Unit 2 of the module on Foundations of Public Health. My name is Dr. Nnamdi Moiteke with the Department of Community and Public Health at Idaho State University. In this second unit of the module, we'll be looking at the wider determinants of health and health inequalities. First, we might ask, what influences our health? The traditional medical model of health is based on healthcare. Health professionals and students often think that health and healthcare are synonymous, or that better healthcare leads to better health. In other words, they think healthcare is the determinant of health. However, even the most generous calculations estimate that healthcare determines only a quarter of the population's health. Therefore, healthcare is what you do when public health has failed. Heart disease, peripheral arterial disease, type 2 diabetes, etc. are ruled conditions that could be avoided. If we had good public health, we wouldn't need a healthcare system to treat these problems. So what actually determines our health? The answer: lots of things that sit outside the individual's control. Our social and economic situation are the greatest influence on our health status, and that makes up about 50%. Contrary to the medical model, the public health approach is based on a social model in which healthcare is only one of many determinants, the so-called wider determinants of health. Here we can see in this diagram from the Canadian Institute of Advanced Research the relative contributions of various determinants of health, and we can see that healthcare contributes probably about 25%. So what are these wider determinants of health? The wider determinants of health include the social, economic, and environmental factors that have an impact on health. These factors determine the extent to which a population possesses those personal, physical, and social resources to avoid disease and manage its health. Most are determined by circumstance, local and national policy, as well as resource allocation. Perhaps the most prominent conceptualization of the wider determinants of health, sometimes referred to as the policy rainbow, was proposed by Dahlgren and Whitehead in 1991. We can see from this diagram the policy rainbow has 4 layers outside of the individual. At the individual constitutional level, we have factors relating to age and sex. And outside that, beyond the individual, and the first layer is the individual lifestyle factors. And after that, the social and community networks. And after that, the living and working conditions. And the outermost layer being the general socio-economic, cultural, and environmental factors. So the Dahlgren and Whitehead framework presents the range of individual, community, and societal factors that impact upon our health. It identifies the opportunities or levels of which to intervene. Many of these factors are outside an individual's control, yet some are not. This brings us to an incredibly important debate in public health, the idea of determinism. Determinism in this context is the idea that people are products of their environment. Now, this idea raises considerable criticism. We have to recognize that people have control over their lives. They make choices, and many of these choices may not prioritize long-term health. But what this gets to is whether we hold people responsible for their lifestyle choices. In the final analysis, individual choice is constrained by circumstance. We have to recognize both wider determinants and personal lifestyle choices as part of the broader picture. We should not blame people for making what we deem poor choices, yet we can't absolve them from this responsibility either. At the center of the rainbow are factors that really are predetermined and cannot be changed. For example, age, sex, and genetics. The surrounding layers present a range of potentially modifiable factors. summarized as number one, individual lifestyle factors like what you eat and drink, your physical activity, and if you engage in risky behaviors. Number two is the social and community networks, which include neighborhoods and communities engaged in thriving and those individual positive interpersonal relationships. Number three is living and working conditions, including housing, employment, sanitation, and nutrition. And the fourth layer is the wider socio-economic, cultural, and environmental conditions, including poverty, stigma, and cultural beliefs. Therefore, the public health approach recognizes that improving health is not as simple as improving access to healthcare services or telling people to eat better or exercise more. The conditions in which you live and work, your community, and interpersonal relationships all contribute to your health outcomes. Dealing with these factors is, in fact, far more challenging than simply receiving a tablet or undergoing an operation as you lie outside your personal control or choice. However, the complexity of health within the public health model means that there are many opportunities to improve outcomes across the population. Children growing up in poor housing conditions are more likely to have poor academic attainment and are at increased risk of unemployment and poverty. These, in turn, are associated with poorer health outcomes. Interestingly, this quickly becomes cyclical. The conditions in which we live, grow, and work have a huge role to play in improving our health and well being. A recognition of their importance underpins public health as a discipline. Let's look at socioeconomic status. Socioeconomic status is a hugely significant determinant of life and health outcomes, and accordingly, there is a plethora of research on the topic. It combines and interacts with a number of other risk factors, including housing, sanitation, nutrition, and employment. Socioeconomic status, the social status of an individual or population group, is composed of three domains: education, income, and occupation. All three of these domains are intrinsically linked and correlate with health outcomes and are all present within the model of wider health determinants that we have described. Higher education increases your chances of higher status of occupation, which in turn affects your income. For this reason, they are considered under the umbrella term socio-economic status. Let's now look at each domain individually and how we might measure it. Educational attainment. Educational attainment affects your quality of life, including income and employment, and it affects your mental and physical health. Educational attainment is associated with a number of risky lifestyles and behaviors and associated with health outcomes. Employment is absolutely central to health and well-being. Workplace stress, instability, or poor working conditions can affect physical health, increasing risk of hypertension, cardiovascular disease, diabetes, and musculoskeletal problems. There is a further effect on mental health, for example, stress and anxiety induced by actual or even potential unemployment. Certain professions also carry a level of prestige in modern society. Occupations also largely determines income. So how do we measure occupation? Surveys monitoring occupation generally encompass two questions. The first is on the particular occupation, for example, a teacher or a web designer. The second is on the industry, for example, government, finance, education, or manufacturing. But categorizing occupation can be quite complex, and job titles are incredibly heterogeneous. You can also have somebody, such as a security guard, who works for an educational institution or a retailer, which are different types of industries. So these pose challenges to using these data. The second challenge around employment data relates to the subtle difference between profession and employment. One might be a dentist, for example, but could be out of work. Therefore, you have a profession, but they might not be employed. For this reason, we tend to consider profession as a corollary of education and qualification. The final challenge, and one that's emerging of late, is that of the so-called gig economy, where individuals don't hold traditional appointments. how we account for and measure such gigs, whether in blue-collar food delivery or white-collar consulting, is really difficult. It's important to note the phenomenon called healthy worker effect. Employment is good for health, but on the other hand, being unhealthy can put you out of work. Therefore, people in employment will normally start off as healthier than those who are unemployed. For this reason, we have to be careful about how we compare employed and unemployed cohorts, as poor health may well be the driver of unemployment, rather than unemployment itself leading to poor health. This is an example of reverse causality or even simultaneity. Income. In a world largely driven by capitalism, income affects almost every single aspect of our lives. It affects the food that we eat, the home we live in, the education we receive, and in some countries also determines the quantity and quality of healthcare that one receives. Higher income has been shown to be associated with longer life expectancy and a number of years spent disability-free and in good health. Conversely, poverty limits the choices that you can make in relation to nutrition, health, and housing. Poor health is itself associated with poverty. Consider the impact on a family with a single breadwinner who then sustains a serious injury and cannot work. There are many different ways to measure income. You might consider professional earnings, family wealth, or investments, and land owning. But who decides what's considered poverty? Is it an income less than minimum wage? Is it an income less than the population mean? There are a number of definitions of poverty. One of them is from the Joseph Rowntree Foundation, which defines poverty as when a person's resources are insufficient to meet their minimum needs. Relative poverty is the inability to maintain an average standard of living. That is, when a person is earning less than 60% of the population median income. Either definition is appropriate depending on the purpose, but it is important to be clear about which definition one is using. This brings us to the concept of deprivation. Socioeconomic status does not take into consideration the conditions in which an individual lives: housing, environmental factors, crime, and so on. A more holistic measure of poverty and inequality at an area level is deprivation, which is defined as a state of observable and demonstrable disadvantage relative to another area. Deprivation is an area level measure that considers a range of factors associated with poverty and inequality, including both material and social deprivation. It's important to emphasize that deprivation is an area level measure, meaning it does not tell you about the status of an individual. So you may have a highly deprived area with a few residents of higher socioeconomic status living within. While deprivation is an incredibly useful and holistic measure, there are actually very few countries with a national index of deprivation. While there is no measure of deprivation systematically used by the United States Department of Health and Human Services, the Centers for Disease Control and Prevention developed a comparable measure called the Social Vulnerability Index. Social Vulnerability Index looks at an area's resilience to external stresses such as natural disasters or chemical spills. The index consolidates 15 different indicators, including poverty, housing conditions, and access to transportation. So now that you know that deprivation is what it is and how to measure it, what happens when you, as a health professional with a public health approach, discovers that an area is deprived? Well, once you identify areas of deprivation with poor outcomes, you have a moral and professional duty to do something about it. Reducing differences or inequalities between areas is fundamental to public health, and we are continuously working at differences in health outcomes by area of deprivation. Deprivation has a strong association with poor health outcomes. In fact, the association between life expectancy and deprivation is one of the strongest arguments for espousing the wider determinants of health. It is our role as health professionals to reduce this gap in outcomes and deprivation experience. As we have mentioned, deprivation is a hugely important measure in thinking about population health inequalities. An appreciation of the indicators for the indicators that deprivation encompasses and the interplay between these factors will help you in thinking about the social determinants of health. Next, we'll be looking at equity and equality. Equality has its roots in the word equal. Equality is when people are given something in equal measure. It's about being the same, but not everyone was made the same. And we know that our genetics define a portion of our health outcomes. There are therefore inequalities in the distribution of health across the population, owing to genetic and other factors. There may be inequalities in resource distribution, likely due to lack of resource or funding. Equity, on the other hand, is when people are given what they need to be successful. Inequity can be defined as unfair, avoidable differences arising from poor governance, corruption, or cultural exclusion. Inequity can provoke outrage and is the result of human failure. In health, it is the cause of avoidable deaths. For example, African Americans in the United States account for just over 10% of the population, but account for nearly half of all HIV infections. There is no biological or genetic reason for this. Rather, there are social and structural barriers to achieving parity and sexual health. This is inequitable and avoidable. The goal in public health is to identify inequalities and health and determine whether or not they are inequitable, that is, avoidable. And if so, whether something can be done to mitigate or reduce them. Here we see a very beautiful picture that beautifully expresses the concepts of equality and equity. This picture is quite famous, and it's a quite famous example by the Interaction Institute for Social Change. It encapsulates the difference between these terms very well. Equality will be giving everyone a stand of the same height, which doesn't lead to equal outcomes. The smallest child can't see over the fence, and the tallest has room to spare and didn't really need a stand in the first place. Equity, on the other hand, will be giving each person to stand at the height needed for them to see over the fence. In public health, the best effort is made to reduce both inequalities and inequities. Inequalities are important to consider in ensuring there's equal access to services, support, and opportunities. Equality and access are what underpin universal services which are available to everyone and anyone. However, what happens when you are still seeing inequalities and outcomes despite providing universal services? For example, is it equitable that someone in a more deprived area receives the same amount of support as someone from a more affluent area? The answer will depend on your political and ethical views and will vary from person to person. However, from a public health perspective, we know that we should be aiming to reduce or mitigate against any inequity or inequality we identify. So you have learned the definition of equality, which is sameness, and equity, which is fairness. We have begun to introduce the idea that our interpretation and acceptance of inequalities and inequities will be influenced by our ethics. Inequities are avoidable inequalities, differences in health. We'll examine now the link between ethical frameworks and our interpretation and acceptance of inequalities and inequities. Let us begin by considering the staggering issue of maternal mortality and inequalities and inequities across the world. Maternal mortality refers to the mortality of women in pregnancy or within 42 days of pregnancy ending. It is a very important health indicator. It is reflective of the quality of healthcare available and accessed and sets the stage for childhood health and well-being. Maternal mortality remains unacceptably high and there are severe inequalities and inequities in maternal mortality rates between and within countries. Around 99% of maternal deaths occur in developing countries, and rates are higher in women living in rural areas and more deprived communities. Maternal mortality is largely avoidable. This map from the World Health Organization represents maternal mortality across maternal mortality rates per 100,000 live births in 2015. The global inequities are striking. Much of Africa, including Sierra Leone, Central African Republic, and Nigeria, topped the charts, whereas Finland, Greece, and Iceland had exceedingly low rates. For example, the lifetime risk of maternal death in Chad is 1 in 16 compared to 1 in 10,000 in Sweden. Why do mothers die, and how is it that we have these preventable differences? Maternal deaths are usually due to complications during pregnancy or childbirth. These are largely preventable or treatable. Severe bleeding, infection, preeclampsia, and unsafe abortion are common situations that can be avoided by provision and access to effective maternal services and policies and cultures supportive of maternal reproductive rights. In high-income countries, women will often have at least 4 antenatal visits with a health professional and receive postpartum care. In low-income settings, it is estimated that less than half of women receive the recommended antenatal visits. This may be due to poverty and inability to pay for healthcare, distance from healthcare, inadequate information or provision of services, or cultural practices. To address these inequalities and inequities in health outcomes, we need to address the barriers that prevent or limit access to and quality of maternal health services. As was mentioned before, health inequalities and inequities are not limited to low and middle income countries. Inequities persist in many of our most developed countries, including the United States, Canada, and the United Kingdom. Let's take Canada as an example. Canada is lauded as having some of the highest quality of life anywhere on the earth. But this, unfortunately, does not extend uniformly to all its residents. Inequalities and even inequities exist between populations, largely driven by differences in socioeconomic status. Let's walk through an example of food insecurity in Canada. If you haven't come across the term already, food insecurity refers to when you cannot afford the quality of food or the quantity of food needed for good health. Food insecurity can affect your mental health and physical health and increase the use of health services, an avoidable burden on the healthcare system. A household survey in 2012 estimated 7% of Canadian adults lived in households that were food insecure. While this percentage is not huge, the prevalence of household insecurity is substantially higher in those of lower socioeconomic status. In Canada, you are much more likely to experience food insecurity if your highest level of education is high school, or if you are unemployed, or if you have a physical disability. Reducing food insecurity and improving access to and affordability of high quality food requires structural changes to the way in which food is processed and priced. That is no small feat. Now you have seen a few examples of inequalities and inequities in practice. We have been quite prescriptive in assigning valid judgment to these situations, and these avoidable differences are morally wrong, and we need to do something about them. However, interpretation and reaction to inequities depends on your personal, political, and ethical values. To what degree are we responsible for our health? How much can be attributed to the environment or society in which we live, and how much is down to our own behaviors and choices? When it is appropriate for government to intervene to level the playing field, at what point do we get to that? When is it appropriate for government to intervene or level the playing field? If you lean towards libertarianism, you might argue that we shouldn't intervene to reduce inequalities and inequities unless our actions are putting others at harm. You might go further and argue that seeing other people living better than you might stimulate you to get more education and training so that you can take on a higher earning job. On the other hand, if you tend more towards collectivism, you might feel more strongly that reducing inequities should be the top priority for society and government. But is it for us to intervene in someone's personal choice for the greater good? You can think about that and ponder on some other situations where it might or might not be acceptable to intervene. That being said, public health in public health we are generally of the opinion that we should intervene when it's for the greater good. You've now learned about equality and equity, two key concepts in public health. We have gone through a number of examples in countries around the world and examined how inequalities and inequities. As a health professional, you will constantly be on the lookout for inequalities and how we can work to reduce them. The participation activity will give you a chance to practice.